Hi everybody, Lisa Herrera here in El Paso, Texas. Well, here we are again. The semester is moving very fast. I'm going to share with you all a case study of a patient I recently took care of on November 7th at the primary care clinic that I'm precepting at. I will present the reason the patient and family came into the clinic, the patient history, my assessment, and the plan of care. GC is a 6-month-old female accompanied by her mother and aunt who present to the clinic with complaints that GC has been having fever along with vomiting and diarrhea for 2 days. Mother states GC has been a little fussy and is not eating her normal amount of formula. GC's mother is the primary historian and is deemed reliable. Regarding my subjective data and the chief complaint per mother, GC began with vomiting 3 days ago, but it stopped the same day. Mother states, we thought she had gotten over her illness when she started vomiting again last night, and now she has diarrhea. GC felt very warm today at Grandma's, so we assumed she had a fever. Regarding the history of the presenting illness, Mother states GC began with vomiting 3 days ago, but it stopped the same day. She goes on to say that everything had returned to normal, but that GC started with vomiting and diarrhea late last night, emesis ×2 and diarrhea ×3. Mother states patient is tolerating her formula but not drinking her usual amount. Last vomiting episode was last night and last diarrhea was about an hour ago. Today, while Grandma was taking care of GC, Grandma stated that GC felt very warm. Mother goes on to say that both she and Grandma do not have a thermometer at their home, but that GC felt very warm to touch, so they assumed she had a fever. Mother and aunt brought GC to the clinic immediately. Regarding the patient's past medical history, GC was born full term with no complications, vaginal delivery. There are no previous hospitalizations. Regarding her surgery history, no past surgeries. Medications, none. Regarding allergies, no known drug allergies. Mother denies any food or environmental allergies. Mother does clarify that GC is not allergic to lactose, she just has a sensitivity. Immunizations and health maintenance are up to date with her last well checkup being at 4 months. Regarding her growth and development, according to Mother, growth is normal. Speech is appropriate for age. Patient is babbling. There are no concerns regarding patient's vision or hearing. Nutrition pattern is normal for age, except that intake has been decreased the last 2 days. GC usually takes about 5 ounces of Similac Pro Sensitive every 4 hours. And Mother clarifies that GC was switched to Similac Pro Sensitive 2 months ago for a sensitivity to lactose. Mother states GC takes rice cereal in the morning and is being introduced to Gerber vegetables slowly. Mother introduces a new vegetable each week. GC usually averages about 9 to 10 hours of sleep during the night and takes 2 60-minute naps during the day. However, she has had increased irritability the last 2 nights. Mother states GC continues with an adequate number of wet diapers and last diarrhea stool was an hour ago. Regarding the family history, Mother, BC, is 26 years old and denies any medical complications. Father, DC, is 27 years old and denies any medical complications. There is a family history of type 2 diabetes, GC's maternal grandfather, but it is well controlled. At this time, GC does not have any other siblings. Regarding the social history, GC lives with her mother and father in a single-level home. Both mother and father work full-time, so GC's maternal grandmother takes care of her during the week. The family is anticipating to enroll GC in daycare next year to get her around more children her age. The family is insured through El Paso First. There are no pets in the home. Regarding the review of systems, according to Mother, Mother again states patient started with vomiting 3 days ago, then again yesterday with diarrhea for a total of emesis ×2 and ×3 loose stools. Subjective fever began this afternoon. Regarding the skin assessment, mother denies any history of rashes or skin abnormalities. Regarding the head, mother denies any history of head trauma. Regarding the eyes, denies any history of eye discharge, itching, redness, or excessive watery eyes. Regarding the ears, denies any tugging at the ears, no drainage, no hearing loss. Regarding the nose, denies any sneezing, rhinorrhea, or epistaxis. Regarding the throat, mother denies any signs, symptoms of throat pain or complications when swallowing. Regarding the neck, mother denies any swelling of the neck. Regarding the cardiovascular history, mother states GC does not have any history of heart murmurs, no cyanosis, no other cardiac complications. Regarding the respiratory system, mother denies any cough, wheezing, or shortness of breath from GC. Regarding the gastrointestinal system, mother does state that GC had first vomiting episode 3 days ago. Vomiting returned last night with diarrhea for a total of 2 emesis and times 3 loose stools. Last emesis was last night and last diarrhea stool was an hour ago. Mother denies any other history of feeding difficulties or abdominal abnormalities. Regarding the genitourinary system, mother denies any foul-smelling urine or hematuria in diapers. Mother denies any previous history of UTIs. Regarding the genitalia, she denies any redness, irritation, or other abnormalities with GC. Regarding the musculoskeletal system, she denies any history of bone fractures or breaks, states that GC is able to move all extremities equally without complication. Regarding the neurological system, mom states that GC does not have any neurological abnormalities. There's no history of seizures, no abnormal twitching, no changes in mental status. Regarding the hematologic system, mother states that GC does not have any previous history of blood transfusions, no easy bruising, and no history of bleeding. Regarding the objective data and my physical exam, general assessment, I see that GC is a pleasant 6-month-old Hispanic female who is sitting quietly on her mother's lap without any acute distress. She is dressed appropriately and she is well groomed. Vital signs are a temperature of 101, heart rate is 116, respiratory rate is 42, weight today is 20 pounds and length is 27.5 inches. Regarding the skin assessment, skin is intact. There are no rashes, no bruising, no scars noted to her body, normal skin turgor. Regarding the head assessment, I find that GC's head is normal cephalic and atraumatic. Her hair growth is normal and well distributed around her head. Regarding my assessment of her eyes, conjunctiva is non-injected, sclera anictoric, lids without ptosis, edema or erythema. Extraocular movements are intact, pupils are equal, round, and reactive to light. Red reflexes noted bilaterally. There is no eye drainage noted. Regarding my ENT assessment of GC, I find equal ear shape bilaterally. The right and left tympanic membranes are both shiny and pearly gray with positive light reflexes noted. There's no drainage noted from the external ear canals. Nasal mucosa is without erythema, drainage, or upper airway congestion. Moist oral mucosa is noted. Her oropharynx is without redness or exudate. Tonsils are normal in size. Regarding my assessment of her neck, the neck is supple. There's no pain noted with hyperextension or hyperflexion of the neck. Lymph nodes, there's no tenderness, no lymphadenopathy noted. Regarding my cardiovascular assessment of GC, regular rate and rhythm are noted. A normal S1 and S2 sounds are noted. There's no murmurs, no gallops, no rubs. Regarding her respiratory assessment, I find her respirations are unlabored, symmetric chest expansion, bilateral lung sounds clear to auscultation without wheezing, crackles, rales, or rhonchi. No accessory muscles are in use. Regarding My assessment of her abdomen, I do find hyperactive bowel sounds noted. Abdomen is slightly distended but soft and non-tender. Spleen and liver are non-palpable. There is no vomiting and no diarrhea at this time. Regarding my assessment of her genitourinary system, normal external female genitalia is noted. Slightly malodorous urine is noted from the diaper. No discharge noted. Spine is straight with no lesions noted. Musculoskeletal system, symmetrical upper and lower extremities, normal range of motion. Regarding her mental status, she is alert and appropriate for age. Regarding her neurological system, I find normal reflexes, normal tone, no focal deficits are noted, and she's responsive. Laboratory data, we do collect a urine culture and UA by catheterization. The UA shows leukocytes are moderate, nitrites are positive, and there is trace of blood. After considering all information gathered from my patient history, the review of systems, and the physical exam, these are the main pertinent positives that coincide with the patient and family's chief complaint. There are episodes of vomiting and diarrhea within the last 3 days. There's decreased formula intake, subjective fever at home, and fever of 101 degrees at clinic less than 24 hours. Episodes of increased irritability at home, hyperactive bowel sounds, and slightly malodorous urine noted on my physical exam. A urine culture and UA were collected, which revealed the following UA results. Leukocytes were moderate, nitrites were positive, and a trace of blood was noted. Ketones were negative, glucose negative, specific gravity was 1030, pH 6. Therefore, my initial working differentials are, number 1, gastroenteritis with an ICD code of K52.9, non-infective gastroenteritis and colitis unspecified. Episodes of vomiting, diarrhea, decreased formula intake, irritability, and fever with hyperactive bowel sounds all led me to have this as a possible working differential. Number 2, viral syndrome with an ICD-10 code of B34.9, viral infection unspecified. Symptoms leading up to this possible diagnosis was episodes of fever, vomiting, diarrhea, decreased formula intake, irritability, and hyperactive bowel sounds noted on physical exam. And then number 3, a UTI with the ICD-10 code of N39. Urinary tract infection, site not specified. And this is due to symptoms of episodes of fever, vomiting, and malodorous urine smell from diaper, along with the urine and UA results that were done at the clinic. So for my final assessment and diagnoses, because of the positive results on the urinalysis, I do come up with the final diagnosis of urinary tract infection, site not specified with an ICD-10 code of N39. And then number 2, non-infective gastroenteritis and colitis, unspecified with an ICD-10 code of K52.9. The pertinent positives from my subjective data include number 1, a subjective fever at home, number 2, episodes of vomiting times 3 days, number 3, diarrhea times 2 days, and number 4, decreased formula intake. My pertinent positives from my objective data include a fever of 101 at the clinic, malodorous urine smell noted during my physical exam, and UA results in the clinic with moderate leukocytes, positive nitrites, and a trace of blood in the urine. Regarding my plan, first, my pharmacological interventions. Number 1, because of the fever of 101 at the clinic, we immediately gave GC a dose of Tylenol. We gave her Tylenol based on, with a concentration used 160 milligrams per 5 mLs, based on 10 milligrams per kilogram. We gave her a dose of 3 mLs, PO times 1 at 1620 in the clinic for a patient temperature of 101. Because of our final diagnosis of UTI, we were going to prescribe 2 medications for home for her. Number 1, Bactrim or the combination of sulfamethoxazole with trimethoprim with a concentration of 200 milligrams, 40 milligrams, and 5 mLs. Dosing is 8 to 12 milligrams per kilogram, with dosing based on the trimethoprim. So for this 20-pound or 9-kilogram infant, the patient dose is as follows: 4.5 mLs PO BID times 10 days. We are dispensing 90 mLs. We also are going to be giving a prescription for Tylenol for home, as mother states that she did not have any at home to treat the fever. So we wrote the prescription for acetaminophen with a concentration of 160 milligrams per 5 mLs. Dosing is based on 10 milligrams per kilogram. For this 9-kilogram infant, we wrote the prescription for 3 mLs PO PRN Q4 hours for fever, and we are dispensing 120 milliliters. Regarding my non-pharmacological interventions for this patient, number one, we instructed and encouraged mom that she needs to be changing the diaper often. She needs to remember, and all people that are helping to change diapers, she needs to remember that we need to wipe from front to back. We also are encouraging mother to invest in an inexpensive thermometer, either from Walmart, Walgreens. It is important to know how high a temperature or fever is, especially in infants. So we instructed her that it's okay to use an inexpensive thermometer, and it's okay to take axillary temperatures with this age group. We encourage her to continue with regular formula. She also may give clear liquids, soup broths, occasional Pedialyte, but no fruits or juices during episodes of diarrhea. Also, if she is going to offer any table foods, bland, soft foods are encouraged. We are instructing mom to follow up in 12 days after the completion of the full course of antibiotic therapy. We instructed mother to call clinic if symptoms do not improve, if GC continues with persistent fevers greater than 100.4, if she continues with persistent vomiting or diarrhea, or if she is unable to tolerate formula, or if she has decreased urine output. Regarding the guidelines that we use to initiate a treatment plan for this patient and for this diagnosis of UTI, the management of care for this patient is in accordance with clinical practice guidelines from the American Academy of Pediatrics, which release revisions to care for febrile infants and children 2 to 24 years of age, 24 months of age with suspected UTI. The revised clinical practice guideline has several important updates based on evidence-based research. The updated guidelines include specific clinical criteria for collecting urine specimen. Diagnosis now requires evidence of infection from both abnormal urinalysis results and positive urine culture results. The criterion for a positive culture was reduced from at least 100,000 colony-forming units per ml to at least 50,000 colony-forming units per ml. Oral treatment now is considered to be just as effective as parenteral antibiotic treatment. Renal and bladder ultrasonography is still recommended, but voiding cystourethropy is no longer recommended after the first urinary tract infection. Follow-up is based on evaluating children for UTIs during subsequent febrile episodes rather than routinely performing repeat urine cultures. The clinician should base the choice of agent on local antimicrobial sensitivity patterns if they are available, and should adjust the choice according to sensitivity testing of the isolated uropathogens. Therefore, based on GC's symptoms of fever, irritability, vomiting, and malodorous urine, a urine culture in UA was collected via catheterization on site at the clinic. Urine will be sent to lab for culture, but initial UA results yielded moderate leukocytes, positive nitrites, and trace amount of blood. Based on GC not having a recurrent history of UTIs, Bactrim was selected as a first-line antibiotic to treat her UTI. Regarding my debriefing of this case scenario. This case study and patient presentation stuck out to me because I wanted to illustrate how important it is to consider all factors before making a final diagnosis. This patient presented with generalized symptoms such as fever, vomiting, diarrhea, decreased PO intake, and malodorous urine, which, as shown, could have led to very different treatment plans. On points that I could have improved upon with this particular case, number one, I think in the beginning I almost automatically was assuming the patient was presenting with a generalized gastroenteritis or a viral illness. I learned not to be too quick to diagnose the obvious and to really consider all sources of infection, the fever. Even though this was just day one of fever, my preceptor and I discussed the importance of considering all sources of infection and decided to obtain a urine specimen on site, which yielded positive UTI results, saving the patient and family from extending the amount of days before we actually started treatment. Number two, I think from my past experiences with treating UTIs, I had been accustomed to my previous preceptors treating with amoxicillin or even Ceftonir. I learned from my current preceptor and from Dr. Alarcon that all UTIs should be treated with a first-line antibiotic first, such as Bactrim, to decrease the amount of antibiotic resistance. Upon further research, I found that although amoxicillin has traditionally been a first-line antibiotic for UTIs, increased rate of E. coli resistance have made it a less acceptable choice, and studies have found higher cure rates with Bactrim. And then number three, I don't think I previously associated vomiting with UTIs, but my preceptor and Dr. Alarcon reiterated the fact that vomiting, especially in young infants, commonly occurs in UTIs and should always be used to help consider and rule out the diagnoses when the patient presents with it. In the end, I think the treatment plan developed was appropriate and practical for the patient and family. I do think GC will respond appropriately and favorably to her treatment plan. This concludes my presentation. I hope this information can be of some use to you in the future. Thank you. Bye-bye.